So the next speaker is Mark van der Gaag, and he's a professor at the University of Amsterdam, and he also works, and has always worked also as a clinician in Parnassia and other hospitals. He's going to tell us a little bit about the mobile that they use to help people in their real life, daily life, who hear voices.
Yes, thank you. When we submitted the abstract, I had hoped that we had some results now, but we had some problems with the Medical Ethical Committee in the Netherlands, because a smartphone is now a medical device and it has to comply to many regulations. And it took us more than 7 months to get this through, so we had a delay. So this is no data yet talk, but I think it might be interesting to see what we have designed. It's a smartphone app. Yes, here it is. And it's made in working together with a technical university. That is the researcher David van den Berg. His wife is an associate professor in industrial design, and that made this collaboration. We started off a couple of years ago with inviting, I think, about 40 students in industrial design, and we had them join the patients for a full day, and then they had the instruction, make an invention in 6 weeks to help these people function better. And that was a very nice start of all the project. There were 19 inventions. Take some time to go to the next. Okay. And this is one of them. It's called aanpakkers in the Netherlands. It was a very clever designed thing to improve the contact of chronic psychotic patients with their neighbors, because everybody was working all day and they were sitting at home doing nothing. And of course, the postal post is not delivering letters anymore, but parcels. And if people are not at home, then you have to go to the post office to collect your parcel. And these were patients, they had a sticker on their door, I will collect the parcels for the neighbors. And so they did. And then at 6 o'clock, when all the neighbors were at home, they went to these neighbors with the parcel. And they're always happy when you bring them a parcel, because they don't have to go to the post office. And they had a small talk. And they, this was a very small, designed way of improving contact with other neighbors. The other one is this app, Timestamp, and there's a little guy, Tim, that helps you through the moments of despair with these voices. It has several functions. It was valued by the patients because it looks very normal to be hitting your smartphone during your hallucinations. As you can see, everybody does this, except for this one. That's a very strange guy, and he pretends to look in the world and doesn't understand that you have to do this with an app. It's not from these times, because when there were no apps, you could see that everybody was reading newspapers in the train. So, back to the Timestamp, which means taming your voice, and Tim. This is the group of researchers, and we're now doing a single-blind, multi-center randomized controlled trial with 2 arms. One group has the intervention, and the other is just monitoring its auditory verbal hallucinations. The aims are to test the effects of this app on distress and on social functioning, and some other effects like control and power over your verbal hallucinations, the ability to cope with it, what does it do with your self-esteem, quality of life, and paranoid ideations. And that has to do with the design of the app. The study is that the primary outcome measure is a experience sampling measure. So it's only 70 days, and there's measurements day by day. There's a morning measurement, there's an evening measurement, and this is the experimental period below. And there's 3 blocks of experience sampling. Experience sampling is a app on your smartphone that gives you a signal 10 times a day, and then you have to answer 40 questions, and it takes about 2 minutes to do so, on where you are, if there's people around, how you feel, if you prefer to be alone, or what emotions you have, what thoughts go through your mind. And that's done 6 days in a row, 10 times a day. So you have these blocks of 60 potential measures. And in reality, that means that you have 40 to 45 repeated measures of momentary, ecologically valid measurements. And there's, of course, also classical pencil and paper assessments. There's several things you can do. The most simple application is this one. That's words, and they are split in 2. And you can turn them around with your fingers, and then you have to combine it to a regular Dutch word. And that's quite fast, and it starts off quite easy, and you have several levels in it, and you can earn points with it. And that's the idea there is that it's convenient to have something to distract you, for instance, when you're in public transportation, and your voices start to wake up and try to bully you or do other things, to do just something with this thing. It's, but we also use it not just to get the voices down, but also to do a kind of EMDR-like intervention with the voices. I'll come back to that later. The idea is that when you hear voices, your language production areas are activated. And that's already a very old knowledge, and I did in the early 80s experiments with humming and singing. We knew that patients that hallucinate also subvocalize, and if you use your vocal cords for something different, that you can't hear hallucinations. So there's only one person that can use your vocal cords. It's either yourself or your voices. And that's a way to suppress them shortly. It's also found with imaging in more recent days. So the idea is that if voices activate the language production area and you start to do something verbal, that this might inhibit the voices. And the third function is that we assess self-esteem, and we look at the reason for negative self-esteem is that you think you're worthless, then you will be rewarded with things like you can do it, you did it fantastic, or does it, if your self-esteem is dominated by thoughts that nobody loves you, you get feedback in terms of you did it real good and you're fantastic, we love you, and that kinds of things. So the feedback is incompatible with the dominant negative self-esteem teams. That's the idea once again. So in EMDR, you have intrusive imageries that are related to the trauma, and the idea nowadays is that by introducing a dual task, you interfere with the reliving images, and they get less emotional. There's an imagination deflation going on. And the idea was, if you can do this with visual problems in traumatized patients, you might do this also with auditory things in these voice hearers. And the idea is that voices are intrusive phenomena as well, related maybe to trauma. And what happens if you ask the patient to imagine his voices and then introduce the timestamp task, and will this interfere with the voices and make them less emotional and less vivid? Kind of parallel to EMDR. So this is the dual tasking idea, that a dual task will make it impossible that that the voices will enter your consciousness. And the big question is, does this help? And this is what I thought about the boosting the self-esteem. Oops, one back. So we asked for the dominant negative thoughts about the self. This says, I'm weak, or the other one is, I'm without power, or I'm in danger, or I'm without any worth, I'm bad, I'm guilty, or neutral. And dependent on what people think is most characterizing their self-esteem, we choose compliments and reinforcing statements that are exactly opposite of their negative self-esteem. It's a nice toy. You can get daily feedback and graphs. And the trial is only just started. We would hope to have all 100 patients in now, but we have now 26 inclusions. The app is already for a long time available for iPhone and also for Android. It's just in Dutch. If this is effective, we will have English and German and French things again. It's been downloaded by patients for thousands of times. A lot of psychiatrists in the Netherlands already use this in patient care. We have a lot of positive responses, but that's always deceiving, of course, because there must also be patients that stop with this app after 2 minutes and they don't email us. So that's the idea. And thank you for your attention.
Thank you very much, Mark. So we have time for questions. Again, if you just want to wave, I'll just repeat the question so you don't have to walk forward. You already answered one, which is it available in English?
No, not
or
yet.
in other languages? Yeah.
I'm also developing an app for another mental health purpose. But I'm just wondering, you've released that through the app stores, so it's available to the general public.
Yeah.
But it hasn't actually gone through any clinical trial process yet. So how do you feel about having released the digital intervention with the purpose of treating a particular problem, having not been through a comprehensive
Yeah.
process?
So the question is, if I might just summarize it, is it safe to basically give it to everybody and make it available before you test it, whether it might be dangerous in some ways?
Yeah, well, that was a bit of a catch-22, because you can only use an app if you have released it. And we hoped that the study would have started earlier. But a colleague of mine in the university has traced 6,000 health apps, and 5 were tested and 2 were effective. So you're right, this is a big danger that we're all going to launch apps that will not work in the end and will erode the trust in mental health. Yeah. So I'm glad we're doing research, and we'll get it off the App Store if it doesn't work at all. Yeah.
Don.
Is there any effect of the training program of the stem cells? Do you expect an effect on the phoning with the chords of your hallucination because of the training? So does it have an influence on biological measure correlated with hallucinations?
Yeah, well,
So the question is, will he have an effect on the biological measures of, for example, the vocal cords movement?
Yeah, well, if the frequency of hallucinations will go down, then it will have an effect in most patients on the vocal cords. It's based on the theory of Vygotsky, who found that most people that learn to read aloud, and then at a certain moment they can read whispering, and then they can read without making any noises. But about 80% of the world population that has the ability to read still subvocalizes. And so there's a leakage of thinking and reading to your expressive motor system. And blocking that also blocks the perceptual side of it. And
is it a 100% correlation?
no, it's a 90% 90% of all people that hallucinate also have subvocal cord movements. Yeah.
So I'm the next speaker, so I'll introduce myself. As I said before, Lucia Valmaggia, and I work as a senior lecturer at the Institute of Psychiatry, Psychology and Neuroscience in London. And what I'm going to talk to you about, this is the title of the talk, but after the talk I gave previously, a lot of people came to me to ask me about what is virtual reality actually. So I changed it slightly. I'm going to give you an introduction to what virtual reality is and how you can use it in psychology, and what the plans are to do with it next. And if we have time, I will tell you about our study. If not, you can look at it online afterwards, because all the slides will be available. So, well, my declarations. So virtual reality really enables you to measure your cognition, so what your thoughts are, how you feel in your body and how your emotions, as well as your behavior in real time. So in what people call an ecologically valid environment. So it's as good as it gets to have a real situation that you can replicate over and over and over again, but show it to different people, and be sure that what you're showing is exactly the same for everybody, so that whatever the person sees in that environment is what they make out of it, okay? And also for those of you who are in countries like where I live at the moment, that are always asking you, well, this is very costly, it's not too expensive. No, there is evidence that is actually cost effective now that the gamers have taken it on and reduced the price of it. It's been along for a long time. A lot of people don't realize this, but it's only been made more available to the researchers recently, because the prices have gone in 2 years from about 50,000 euro for a headset to less than 200 euros. So because the gamers got involved, the prices, and they developed nice new stuff, the prices went down a lot. So how is it used in psychology? It's used in basic psychology to study mechanisms, to study how we respond to, for example, if something comes at us and you look towards it, if it comes from another angle, would you respond differently? Neuropsychology, so much more to create real-time situation where you can see how people respond. Oh yeah, I thought I was already talking for 12 minutes, but it's going down. I was like, oh Jesus. Okay. Where you look at cognitive function but in real life. So for example, the classic is a person that comes to you and you need to do a test on paper and pencil. They do it okay, but then they go to the supermarket and then they can find their way back to the exit, because the cognitive impairments are different than on a paper or pencil task. So the idea is that with virtual reality, you can put them in a supermarket, a virtual supermarket, and ask them to buy their grocery in a virtual world and see how they cope with it, okay? And then what we're going to spend more time in talking about today is more the use of it in assessment and treatment, so more the clinical psychology use of it. This I touched upon very briefly already, but is the idea that there is, if the cognitive model, which has been around for a while, of course, and if there is an event or a trigger, the way you appraise it will influence how you feel, how you behave, and your physical response to it. And that will, of course, the way you appraise it will be impacted upon or influenced by all your life, so what you experienced before, but also by your cognitive capacity, how you can process things, how quick, or whether you can still concentrate or not, and all of those things. Okay, so the same situation can be appraised by different people. The problem we always have in when we talk to clients that come and see us is that we don't know whether what they have experienced is indeed a response to maybe some of their behavior, and they are right in being paranoid about it, or whether it's them reading more in the situation than what there is to read. And that's what virtual reality allows you to do. It allows you to create a situation that can be replicated. At the same time, it also allows you, and we will see that in Rose's talk, to modify things in the world so that you can modify how people respond by helping them coping with different things. And Mar showed that as well in her talk with the voices. So it's been already used to investigate the mechanisms behind it, and we published that this year in social psychiatry and SBQ-pd anyway. Well, the reference is there, and you can read more details if you wish. And I'm just going to very, very briefly tell you what is also been used for many years with good success. And I'm doing that because a lot of the early intervention and early detection work we do is not necessarily directed at the main problem, but people always present with more than one thing. So with phobias, it's been used a lot and very extensively, and also has been shown to be a safe and effective way of treating, for example, if you're afraid of heights, or if you're afraid of spiders or dogs or whatever other animal, but also more functional, for example, if you're afraid of taking a flight. There's been done a lot of work in there. OCD is an example. So this is a nice clean toilet, and you can make it a bit more dirty, and you can make people touch all kinds of dirty things in it, okay? So again, if you think you could do it in a real toilet, yeah, but this is a bit less, okay. So eating disorder is another area that has been extensively researched and has been shown that is very useful in eating disorder, both to research the body image, so how people perceive their body compared to other people, as well as exposing a kind of exposure treatment for people to get used again to be around food. So to be in a restaurant, to go to a restaurant, for people who really become phobic almost about those places. And it's a good point now to point out that it's not meant to be the real thing. So you want, well, you can, people have done it, add the smell of food, for example, but it's more like a kind of in-between safe place where you can try things out and build the skills that will then enable you to really try outside. PTSD is definitely the field that has done most research. This is Skip Rizzo. He works in California. He's done a lot of work with veterans from the US Army. And I got links. I'm not going to activate them, but if you want to look at their work, you can click on them. And what they found, interestingly, and I'll show you a little bit more about it, is that some of the soldiers who are very traumatized actually prefer to do the virtual reality than talking to somebody, because they find it easier not to show the emotion when they're so traumatized to real people. But that helps them to then disclose some of what they've encountered while they were away. And I think we can also learn something from it, despite the fact that it's sponsored by the Army, to also maybe help some of the new refugees that have experienced a lot of similar environments, but not within, not as a soldiers, but on the other end. So it's worth thinking about it if you work with those populations. Pain has also been very interesting, has been used very effectively with burn victims. So these are people with very severe burns. And what they do is they show, while they are medicating you, if you have burns, is extremely painful, because each time they touch you is very painful. And they've shown, learning from imaginary techniques that we know work if you think about something cool, you feel a little bit better. They show you a game where you have to play with snow and you are submerged in snow. And they've shown that the pain goes down a lot. And the key is that you feel really immersed in it, so you really feel like it's there. This is work that Mar, who spoke earlier, she wasn't asked to come and work for the Avatar for nothing. I'm sure they selected her because she has a very long background of working in virtual reality. She did a lot of work before coming to London in Spain, which is, by the way, one of the most advanced places in virtual reality and mental health research in the world. And they do, her particular study was on social skills training for people with long experience of chronic symptoms, what people call chronic symptoms, long-standing symptoms of schizophrenia, who did not respond to the traditional role play kind of setting, but they did all kinds of role plays in virtual reality, and they've shown, and this is the paper if you want to read a bit more, this is the pilot, but they published more data on it. They've shown that this is not just more effective, that people, A, enjoy doing it instead of a role play. We all know how much we love role plays. And B, they also, it translates better and generalizes better to real life than role plays. Avatar, well, I'm not going to say anything because you've already spoken about it, that this is the reference. And then we come to the VR-assisted therapy, which is a bit more recent. And these are examples of VR-assisted therapy for psychosis. So I'm not going to spend any time on what Rose is going to talk about in a second. I just want to point out that probably the person who until now has done most work in this area is Daniel Freeman with his colleagues. And it's worth, if you're interested in this kind of area, please check out his work. And it's basically, again, based on the idea that if you go into a social situation and you become very paranoid, being able to try this social situation in a virtual reality environment and try different skills and different things can help you. And if I'm going to tell you a little bit more about what we do as well about it, can help you overcome some of these, for example, avoidance behaviors that you have, and encourage you to try different strategies. So VR-assisted assessment and treatment is what we also do, and this is, I got 4 minutes, so it's cool. So what we have done is we developed a therapy package, if you like, where we have different environments that you can break down in steps. So in this case is a pub, an English pub, and you can walk to it, then you can enter the pub. Once you've entered, you have a few interactions, and each interaction we can modify. I'm sorry, in the back you probably can't see it, but here it says how loud it is, how many people look at you, how many people laugh in the background, but also comments that people who experience this kind of paranoia and uncomfortable feelings in a social situation have told us that they often misinterpret as saying something about them. So comments like, look, what a joke, what a loser, and they think people are talking about them. So we can also make those 0 or make them very, very much. So we can modify those and help you, or, we can make them very bad so that you have, if you can cope with that, you can cope anywhere, basically. And I'm just going to show you, and Guillaume has been extremely helpful because I stupidly copied the video from an Alienware computer, which for the gamers around you is a very fast, very cool computer. But of course, these computers can't cope with it. So it's been extremely helpful in converting that for me. It's a tiny bit slower than real life, but the audio works very well. Thank you.
You have been invited to a party in the pub. Please join some of the guests and try to make an impression of what you think about them and what they think about you.
Hi, welcome. My name is Patrick.
Okay, thanks. Yeah. So what you don't see is that the audio is not matched with the. So what you will, once you get to the green spot, Patrick comes at you and says, "Oh, hi, I'm Patrick. Welcome to my party," and then turns around and says, "Hi." Nice to, guys, this is our new guest. And everybody turns around and waves and say hi. So that's just one of the scenes that you are encountering. Thank you. And we put the green spot so that people know where to go, basically. And you go from one green spot to the other. Okay, so again, coming back to the work that has been done and in other area, again, coming back to the skip reason, just telling you what the future has on hold for us. This is a computer system that actually, and it's probably of interest for people who work in places like, for example, Australia, where some of your clients might be too remote for them to come and see you all the time. This is software that reads how you respond and adapts the response of the avatar to what you're saying. So if you withdraw and you look back, the avatar will immediately respond and say, how are you feeling, how you're doing? And it's still very much in the early stages, but it's coming, and it's coming very quickly. And I think it will be very interesting. And this is another one that they've done where you can load online. You can go, everybody can go. And you have here on this side, you have questions that you can ask this guy, and he tells you how it is to access therapy. And he's developed for soldiers, so the language is similar to the one that you would think the stereotype soldiers will use, but has improved a lot of access to therapy in their particular area. Other example, this is for young kids, is an app. This is a fantastic, it's not virtual reality, but it's a fantastic program. There are leaflets outside. It's to help carers who have a family member with psychosis, who learn more about what psychosis is, what schizophrenia is. Juliana is in the audience. I'm sure she will be happy to take questions if you have them. And as we just heard, wearables and smartphones can be integrated with this type of interventions. And then our studies, you will read about it later. Just want to end with the fact that if you want to read more, these are the people I work with, and if you want to read more, we have a website, and I'm a keen tweeter, so please do follow the tweet sign. And I'm in my time, so that's it. Do you have any questions for me? Yeah. I'm very happy to, but I don't want to take up time from other people, but very briefly what I can tell you is that we basically tested people from the general population to see whether this environment was effective in generating different emotion and different, and also paranoid ideation. And we only recruited by Twitter. I can recommend it to everybody. We recruited 609 people in 4.5 weeks. And they all did all the assessments online, and we then selected the people with high and low score paranoia, and we found that indeed the high scorers, even in a general population, were much more likely to become paranoid. So we are now confident with service user is safe to proceed. Any other questions? The problem here is that you have these slides who completely blind you, so. No? Okay, so next speaker is Rose.
And Rose is gonna tell us about her study, fantastic study that they are doing in the Netherlands. I just briefly pop it up, and it's to help people who have paranoid ideation and paranoia, actually quite severe paranoia, to cope with it better.
Thank you, Lucia, for the introduction. Just very briefly, my disclosure. But I want to start with just very briefly why we wanted to develop this treatment. And I think you will recognize these clients I talk about, because we see a lot of clients and they are very socially isolated and they can become very lonely. And they would like to move back into the world and reconnect with people, but it's very difficult to do that if you are afraid people might be out to hurt you, or people might be after you. So that's why we wanted to create a safe learning environment, exposure environment, to help people deal with this. There's a treatment protocol we developed. It consisted of 16 sessions. We made individual case formulations, and the sessions were twice a week. There were 40 minutes of virtual reality exercises, post-exposure and behavioral experiments in every session. And we targeted the maintenance factors of paranoid ideation, so either behavior, but also maybe jumping to conclusions or having selective attention for threats. The therapists we trained were all from the field. We had seven institutions who participated. We gave them a 2-day training, we gave them supervision. And very importantly, this is for the clients, we did not give any homework exercises because we really wanted to see what the virtual therapy would do in the real world, how it would generalize. These are the worlds, the virtual immersive worlds we created. They are highly interactive. Maybe you recognize the cafe. We did some earlier talks about it. And then we also asked our participants, what are the environments, the social environments you are most afraid of? So we could recreate this. And the supermarkets, just the streets or shopping streets, and public transport were most mentioned by most of our clients. So we decided to go with these. As a therapist, you can at any time control these environments. So if there are too many people, you can send some virtual people away. You can manipulate how nice these people are, whether they are male, female, how many. You can even start with just an empty world if someone's very scared. And you can also make them say things like you heard from Lucia, what a loser, what is he doing, sort of ambivalent sentences or even negative sentences people can be very afraid of or can interpret it for themselves. This is our method, just very briefly, because you can read the full trial protocol if you're interested. We published this. But we did, it was give half of our people the therapy, and the other half was put on a waiting list, and they would receive the therapy after the waiting list. We would do a baseline measurement. We would do at 3 months, just after the therapy, because there were 16 sessions 2 times a week, so we would do that within a 3-month time frame. And then we do a 6-month follow-up also for both groups. We did, of course, the pen and paper and pencil interviews, but we also used the earlier mentioned PsyMate, because then with the PsyMate you can actually measure in real life. You can ask people, are you in a social situation? Who are you with? How are you feeling? And that's what we wanted to know. For the Green Paranoid Thought Scale, we did some extra measurements with that during sessions, so I will show you those as well. There's an app for it now, but we use the old version. The old version, just a little box which would ask the questions, and they would ask that for 6 days, 10 times a day. And there are those are our main outcome measurements. We would use momentary paranoia to decide, to see how during social interactions, because now we could filter those, how during social interactions their paranoia was for our clients. Also the anxiety during their social interactions. And we also wanted to know maybe if we could already see a little bit of increase, like for social participation. And we classified social participation if people would say, I am alone, or I'm with a mental healthcare worker, we would classify that as no social participation. If they were with friends or with just people they do not know, we would call that a social environment. The upper part of our flowchart. As you can see, very important, because I will come back to that later, that there were some people who would love to have treatment, who were having these symptoms, mild paranoia, at least avoiding one social situation, but they were too afraid to travel to our treatment location. So that's good to know. Very briefly, the inclusion criteria for our study were very broad, so we would include everybody with a psychotic disorder who would also suffer from at least mild paranoia and avoid at least one social situation. Exclusion criteria were that they, at the time it was not yet known if epilepsy was safe to use with virtual reality. We do know it's safe now, but we did not know, so it was an exclusion criteria for us. An IQ below 70 was an exclusion criteria, and not enough knowledge of the Dutch language, just because we had all these questionnaires to fill in, and we did not want to make it stressful. So 58 people received the treatment intervention. 12 of them discontinued, and I thought it might be interesting to talk a little bit about why. And as you can see, most of the, if you think back about the treatment protocol, we had 16 sessions, and we used the first 2 sessions not for virtual reality treatment. And we used the first 2 sessions just to make an individual case formulation and to talk about the client, which specific goals they would want to reach within the therapy, what their therapy goals were like. And you see most of the dropouts even before the start of the virtual reality. We did do a 5-minute just training exercise in an empty virtual world. So people would get used to the technological, like the head-mounted display and how they could use the controller to walk in the empty world. And one person got cyber sickness. I don't know if you've heard this maybe in other talks before, but it's sort of like a motion sickness you can experience. Some people can experience if they use a virtual immersive environment. 2 people dropped out because they did not like our head-mounted display. This is the one we used, and to be honest, it was not very comfortable. So with the new models, we hope that would become better. It was very, it was not comfortable. Okay. I'm not sure. Yeah, you can. I think you can read this. These are just our socioeconomical, demographic data. And I think most people in the trial had schizophrenia. They had an average duration of illness of about 14 years, so quite a while. Most of them used antipsychotic medication. And the average age was about 38. So does it work? These are 2 of the measurements we did with the PsyMate, the ecological assessment. And what we did was use multi-level mixed model analysis, and we controlled for age, and I'll get back to that. And you can see that the treatment group had a decline in momentary paranoia at the follow-up, at the post-treatment, but also at the follow-up. This was quite a large effect. For the anxiety, you see a similar pattern. Its effect is a little bit more moderate. And then the social company. We did not see any significant treatment effect yet at the follow-up. We did start to see, it's just a small effect, but we did see an effect at the follow-up. But I want to translate this as well to what it looks like in clinical practice. For example, with the momentary paranoia, we had this one guy who would, he's about 40 years old, and he's married, and he would go grocery shopping with his wife. And he would get very anxious and paranoid when he was in the grocery store about maybe people were keeping an eye on him, and if he would move too slowly or be too slowly at the register checkout, people would call police or mental health hospital, and he would be forcefully admitted. You can imagine he was very anxious. And the therapy really helped him to lessen the thoughts, but also it very much helped his relationship. His wife told us later that he would become very snappy at her when he was paranoid. And now the grocery shopping was much more fun to do together. Another example is that we had a guy, and he was so anxious during grocery shopping as well. We had a lot of people having problems with this, that he would only be able to shop for 1 or 2 items at a time. So you can imagine that then the anxiousness would get this high, and he would just get out as soon as he could. So he had to go back a lot of times during the week because he was only able to get 1 or 2 items. And he was very happy at the end of the treatment he was able to be in the supermarket and do whole grocery shopping for the week. For the social company, to give an example, you see small effects, but sometimes it can mean a lot. We had a guy who was a Star Wars fan since the 70s. This really something that was important in his life. And now, of course, we had the new movies coming out in 3D, in a large theater. And his treatment goal was being able to go to the new Star Wars movie. And he did, so he was very happy about his treatment goals. So this is actually how it translates in clinical practice. These are more, I think more people know these measurements, so I took them in as well. These are the green paranoid thought scale. They measure paranoia. And what's interesting is that you see that the T1 is measured at the 4th session, and the T2 is measured at the 8th session, 8 out of 16. And you see an overall decline mostly between session 4 and 8, which is quite quickly if you think about it. Especially since the duration of illness is almost 14 years for most of them, and they've been having problems with paranoia and anxiety for a long time. Because this is also early intervention, I wanted to show you a bit how our younger group was doing. In the Netherlands, we had all of the VIP teams, but some of them had criteria that was up to 35, and some treated people up to 40. So I just still to show you some results for everybody under 40. And you see similar results at follow-up at end of treatment, and maybe even a little bit better at the follow-up. But they do at least as well as the overall population. And as I mentioned earlier, all our analyses were controlled for age. These are the subscales, and you see that the social reference, which is more about what Lucia talked about, that if you hear something a bit ambivalent, that you think, maybe this is about me, then you see that it's a very steep decline between session 4 and 8. And for the persecution, which is more that people are actively out to get you, then you see a decline both between session 4 and 8, and both at session 4 and at 8. And we also saw that these effects were significant, interaction effects with the multi-level. Here again, I added the line for the younger people, and you see they do at least as well. Those were numbers, only about 25 clients, so I didn't do any analysis on it, but you can see they do at least as well as the overall group. This is safety behavior. What it means is that if you avoid a situation, that is called safety behavior, but also if you are in a situation, that you have certain behaviors that will help you lessen your anxiety at the moment. We had a lot of clients, and you can see this very well in the virtual reality, who would not look people in the eye. They would look at the floor, or they would look at somewhere below here. And as a therapist, you can see on one of the computer screens what the client is looking at. So we saw this happen a lot. And those are safety behaviors in situation. There are several more, but those are the main. And what we saw was that between at the end of treatment effect, and the treatment effect is also at the follow-up. And the main decline we found was actually not in avoidance, but in the subscale of in situ safety behaviors. So, for example, looking at people or being very quick about your groceries instead of just doing them. So there seems to be main change. Here you see also, just briefly, for the younger age group, doing, again, just as well, at least, as the other. The result of this study, I think, can generalize very quickly to real-life treatment situations, because we used just regular mental health clinics. We used therapists with a very high churn rate. Most of them were able to do 2 or 3 therapies, and then they would get another job or go into a follow-up learning environment. They had, some were just graduated or not even, and some had lots and lots of years of experience. 2 days of therapist training, but in the Netherlands there is always a CBT. Most therapists are already trained in CBT, so that might have helped because we have a CBT intervention. We may have a selection bias, I'm almost finished, because the most avoidant clients were not able to travel to the location. So hopefully when the new technology becomes more mobile, we can help them as well. And we, of course, can get lots more environments and interaction abilities to personalize the treatment and need a longer follow-up, I think. Thank you.
Thank you very much, Roy. So, again, I know we are all a bit tired because it's the end of the conference. Any questions? I have one, but okay, I'll start with mine and then people can think. So you mentioned the implementation because that's a big issue. The implementation,
Yes.
so that people actually use it in day-to-day
Yes.
clinic. And you said you employ people who are still in training.
Yes.
Do you think they will be able to take it with them wherever they move on? Do you think there will be finance to pay for it when they move on?
To the
The therapist, I mean.
Yeah. But what we did see was we had we trained some psychologists in training yet, and one of them ended up in one of the facilities where they were already working with the virtual reality, but in another department. And she really is right now trying to, she's giving demonstrations with the virtual reality sets already available and trying to get her colleagues involved as well to see if they can go include clients. Yeah.
Thank you. Any other burning question? If not, can I invite you, Wim? So Wim Velin, thank you. So Wim Velin is associate professor at the University of Groningen, and he's kindly agreed to summarize everything we've just seen together and give us some critical thoughts about it.
Yeah, thanks. I'm very happy to be here. I remember 4 years ago we had one of the first symposium on virtual reality in psychosis research, and that was quite novel. And yeah, people were curious, but nothing was known about what we should do and how it would work. And now, only 4 years later, when I was at this conference and I hear the talks and I see the posters and I talk to people. Then you see technologies everywhere. You see, I've seen lots of posters on apps, on video games, on virtual reality interventions. So there's really something growing here, and this symposium is a great example of that. It's exciting to see, but I think we are only at the beginning of discovering what this kind of technology can do in our field, and maybe we are at the beginning of a new era. And you hear and you feel that the expectations are really high in the field. But it has to be demonstrated what it adds. And we have seen here in this symposium a few great examples of what technology can bring. So a few summarizing remarks on the talks. Mar presented some preliminary results of the Avatar RCT, and it's a really creative idea. It's an example of how you can bring technology as an extra factor to help patients cope with their symptoms. So for me, that's an important thing for what technology should do. It should not be because we have it, or it's fun, or it's beautiful, or it's nice to work with. It really should add something to our interventions. And the avatar therapy is an example of that, because you can help people actually to get more control over their voices. And it's also a very nice example that it's really a lot of work to show that it really works, because we still have to be patient. We still haven't seen the final results of this trial. But Mar shows that you have to do all kinds of other things before. You have to see, does it really work? Are patients involved? Is there enough presence? Can you maintain the level of presence throughout the sessions? There are all kinds of things you want to know before. Because there was a question from the audience, and Mark answered that. There are all kinds of health apps and all kinds of new fun things that you can use, but we actually have no idea what the effect is. So we really have to be very careful to do our research before we have all kinds of great stories about it. We have to demonstrate what it adds, and we are doing that. Mark told us about the TEMSTEM. This is an example, and I'm excited about that. It's about technology in the daily lives of people. Because one of the things that's difficult for us in treatment is that you are in your office and talking to people, whereas it should happen in people's lives. TempStem is an example of an app that brings that technology to the lives of people. And it's also an example, and I think we should remember that we should collaborate with other fields. Because Mark showed us that when you had one session with industrial design students, you ended up with 15 brilliant ideas how we can improve our treatments. We are sometimes in our box and we cannot think of creative ideas, and we need other fields to get better treatments. We see that also in the VR studies where you collaborate with game designers and software engineers, that these people, they have so much knowledge and so many great ideas that really improve our interventions. So we have to collaborate much more than we do. And it's also important, again, to be stressed that we need rigorous research to test all these nice ideas. Lucia gave a great overview of what has been done in the field of VR in psychology. And actually, well, I'm impressed again by how much work already has been done in the field. Not so much in psychosis research, we're only beginning. But there's lots of great examples of studies in anxiety disorders and in eating disorders and all kinds of other disorders that we should use. We should learn from these studies. That's what you said, Lucia. We have to learn from what they have done and use it in psychosis research. And two things about that. One advantage of virtual reality that it increases ecological validity, and at the same time that's a little bit the concern and the question we always have. Because you can build all kinds of environments and you can expose people to those. But are these environments really ecologically valid? Because they are not reality, of course, not even close. So we still always have to check whether it is ecologically valid enough. And I think Rose's study shows that it can be. And I think it's great to see the main results of the virtual reality assisted therapy for paranoia, because it's the first large randomized controlled trial with VR assisted therapy. And we are very happy with the results that you can see that you really can make a difference in the lives of people with psychotic disorders, and that it generalizes. You've seen the pictures of the virtual environments. They are not really naturalistic, they are not photorealistic, they are not great. But it works. It's ecologically valid enough because we see that the primary and the secondary outcome measures in real life, that they change. And what strikes me in this kind of research is that, and that's what we didn't think of so much before, that you can even help people that you could not treat before. Because we've seen, and that's also the examples of the PTSD, the soldiers, that they were too scared or too ill to be treated. And we've seen that in this trial as well, that people who have had CBT and exposure in vivo have failed to do it because they had too much symptoms and their level of distress was too high. And with VR therapy, you can actually build it gradually, and you can start with an empty supermarket or an empty street and just let people gradually learn to deal with their own fears and distress. So again, this is an example. If you work with technology, with apps, with virtual reality, always try to think of what can we add with this technique, with these technologies that cannot be done in another way. And you will be surprised what kind of things you can do. So there's a lot of promise. Technology is everywhere, games are everywhere, and well, you showed some data about virtual reality in the last few years, but virtual reality is everywhere this year and in the coming. So you can buy it in every shop, the virtual reality glasses for nearly nothing. You can play with it. There are games. Every smartphone company produces virtual reality glasses. So it's everywhere, so we should really use it. But what are the challenges? I think we need much more interaction in these virtual reality environments, and we need to develop them closer to the real world. We should make more personalized, because that sometimes was a problem. The therapists really had to be very creative to make it match the experiences of the patients. One of the other promises is that you can actually monitor the responses to patients live to complex social environments. But what do? We ask them, how do you feel? But there is a promise that we may be able to use physiological measures or even brain imaging measures or EKGs or EEG or even eye tracking devices to understand much more about what's going on. So it's not only about treatment, it's also about mechanisms of psychosis. And we are going to learn a lot about that in the coming years, I'm sure. Then, to finish, we live in a conservative world as clinicians and treatment and in healthcare. Healthcare is a very conservative world. So you already had a question about implementation. I think that's really a challenge in the coming years, because we have seen over the last few years that implementation of e-health and scaling up of these kind of interventions that's really difficult to achieve. So many therapists don't see the need, or there's financial problems, and you see often that after the research is ended and they're successful and the publications are out, then it stops. So we really have to collaborate, I think, with industry, with companies, to see how we can actually implement this, and we cannot do it alone as healthcare. So we need the collaboration very much. And we need ambassadors to do that. So I think we may need a paradigm shift and to open up, and to open our windows to the outside world, and to collaborate with all kinds of other fields, with industry, much more than we have done so far. So my message for you to take home is go out and do it. And many of you are already involved in those kinds of things. And I would encourage you and ourselves, please be in touch. We have to share our ideas, because we all make the same mistakes, and we have to avoid that. So go out, do it, share your ideas and experiences, and we'll see great results over the coming years. Thanks.
Coffee, I guess. And if you want to come back for the, please do, for the closing remarks and also the announcement of the next conference in half an hour.